welcome everyone. We're going to go ahead and get started. Thank you for joining us today for our webinar From Data to Action, using Maternal Mortality Review Committee recommendations to address disparities in pregnancy-related deaths. And many thanks for your patience as we worked through a few logistical issues getting started today. Quickly, today's webinar is sponsored by the Maternal Health Learning and Innovation Center, which is a project funded by the Health Resources and Services Administration. Here you see our MHLIC partners. And very quickly, you see here just the acknowledgement that the information today are the views of the presenters and don't represent that of HRSA, the Health and Human Services Administration, or the US government. And quickly, you saw these objectives when you registered for the webinar. Today's presentation is going to be led by the CDC, sharing their wisdom and their work on maternal mortality review committees for the benefit of the state maternal health learning and innovation teams and those working more broadly in the maternal health space. So we'll be describing how MMRC data can be used to drive action, to identify disparities in data that can be used to prioritize implementation of recommendations that promote equity, and just reflecting on how public health, clinical, and community partners can engage in moving recommendations into action. Today, our key presenter is Julie Zaharatos from the CDC, who's the Partnerships and Resource Lead with the CDC Maternal Mortality Prevention Team. She has a wealth of experience in this area, working on the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality Initiative, or the ERASE-MM, where she provides technical assistance and problem solving for state-specific needs, applies a health equity framework to the maternal mortality review committees, and she herself has served as a member of the Georgia Maternal Mortality Review Committee from 2014 to 2016. So without further ado, I'm going to turn it over to Julie. It's going to take one moment just as we load up and bring up her presentation, so bear with us.
So Christine, maybe you've already done this, but if you can go to the second slide, I'll do a quick overview and try to move quickly through the front matter. Thank you all for registering. We're going to talk today about how your jurisdiction, maternal mortality review committees, collect data for action. We'll review the CDC's Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, or ERASE-MM program, and our work with MMRCs, data from MMRCs in 36 states, some examples of how states have used their MMRC data, and have some time for questions and discussion. If we go to slide 3, this is an overview of our program and how we support jurisdictions. Some of you may already be familiar with this, but if we start at the green box on the upper right, we help support states in their vital records quality assurance in order to identify pregnancy-associated deaths. We help support staffing for Maternal Mortality Review Committee coordination, case abstraction, and interviews. We provide support for your committee leadership, your chairs, and your facilitators. We also provide support on data use, if you look at that green box on the lower left. And this includes support for analysis and even SAS code for analyzing data. And moving on up, community engagement in MMRC processes and/or dissemination of recommendations. And lastly, implementation of recommendations through program delivery or partnerships with clinical and non-clinical partners. That's the action cycle. And if we go to the next slide, slide 4, this is something that may be familiar to some of you. Some of you may have heard the analogy that maternal mortality is the tip of an iceberg. This pyramid is showing something similar, how your MMRCs collect data that fuels action. that pregnancy-related death is a tragedy at the very top. But if we can get every state to comprehensively review every death and make recommendations for action on their pregnancy-related deaths from their multidisciplinary review committees, and then work with partners to act on those recommendations, we can eliminate, or we have this vision of eliminating preventable maternal mortality and also reducing maternal morbidities and improving population-level maternal health. On slide 5, this is a big question that your review committees answer. What were the circumstances surrounding deaths, and how can we prevent deaths like this in the future? We go to slide 6. This is just a quick visual on how dynamic your Maternal Mortality Review Committee can be. You see a group of folks sitting around a table piecing the puzzle of this tragedy together. They're pulling in vital records like a death and a birth certificate, but also social service records, and combined with medical records like autopsy reports and hospital records, pulling in Medicaid claims data, prenatal care records, and maybe even a close contact interview. Again, the table is meant to be very dynamic and multidisciplinary and representative of the folks in your jurisdiction who touch the lives of people during and within a year of pregnancy. And it ranges from your maternal fetal medicine specialists to your rural health association to your pathologists, your patient advocates. And I think it's important just to touch on what maternal mortality review is. It's an ongoing, anonymous, and confidential process of data collection, analysis, interpretation, and action. It is guided by statutes and rules, and it's intended to move from data collection to prevention. It is not a mechanism for assigning blame or responsibility for any deaths. These reviews, again, are confidential. They're de-identified. The names of the person who died and the people who cared for them are not named in the review. It is not a research study, and it is not a peer review, an institutional review, or a substitute for those inquiries. We go to slide 7. These are the key questions that review committees answer. Was the death pregnancy related? What was the underlying cause of death? Was the death preventable? What contributed? And what actions or recommendations might have changed the course of events? That was a very quick overview of what your MMRCs do. Now we'll get into looking at some of the data that they produce. So on slide 8, this is a map of the 36 state MMRCs that contributed data on pregnancy-related deaths from 2017 to 2019. There were over 1,000 cases in that time period that were entered into CDC's data system, which we call MARIA, or the Maternal Mortality Review Information Application. And before I continue, I'd like to just take a moment to acknowledge that as I present these numbers, that there are lives lost behind these data. And each number represents a tragic loss to a family and to a community. We go on to slide 9, and some of you may have seen this data brief already, but to some folks who aren't familiar with our field, they're surprised that 53% of pregnancy-related deaths occurred 1 week to 1 year after the end of pregnancy, because that's a time when most individuals would have left the hospital. So we're really talking about understanding what's happening during and within a year of pregnancy in our country and how we can get better care to get better outcomes. And so these data really show the importance of continuing to care for people in the postpartum period. If you go to slide 10, this is just some methodological information about how maternal mortality review committees code underlying causes of death. If you go to slide 11, there's the list of the pregnancy-related death codes that are in our MARIA data system. These are the codes that your committees use to understand and then aggregate what are the leading causes of death. So if you go to slide 12, these were the most frequent underlying causes of pregnancy-related deaths in the 36 state data. Mental health conditions was the most frequent overall. We go to the next slide, slide 13. we're going to look at the data by race and ethnicity because it's important to do this, to look at underlying cause of death by race and ethnicity to understand where there are opportunities to address disparities. For Hispanic persons, the most frequent underlying cause of pregnancy-related death was mental health conditions. On slide 14, among non-Hispanic white persons, the most frequent underlying cause was mental health conditions. And then you can see how these data change when we look at other races. The racialized data on slide 15 show us that the leading cause among Asian persons was hemorrhage. And then if we go to slide 16, we see that among non-Hispanic Black persons, cardiac and coronary conditions and cardiomyopathy are the two most frequent underlying cause of death. When combined, these causes that involve the heart represent almost 1/3 of pregnancy-related deaths among non-Hispanic Black persons. And so, again, I'd like to underscore that we need to understand the leading causes of pregnancy-related deaths to disproportionately affected populations in your jurisdiction so that you can prioritize interventions to close the disparities gap and improve overall population health. Some of you may have been in Denver this week for the Perinatal Quality Collaborative National Meeting. I heard Georgia, for example, their Perinatal Quality Collaborative showed that their leading cause of death among the disproportionately affected population here in Georgia, which is Black people, is cardiac and coronary conditions and cardiomyopathy, similar to this national data. And so they prioritized the cardiac intervention safety bundle to work toward intentionally closing that gap. And if we just go to slide 17, I just want to show a statistic that many of you may have seen in the media, that 84% of these pregnancy-related deaths were determined to be preventable. And these are determined at various levels and sometimes in combination. And they're determined at the community level, the system level, facility, provider, and patient and family level. So there are all different factors, and on average, 3 to 4 factors can go into any one death. So it's never just one thing that made the deaths happen. And again, most of these deaths are preventable, but it can be a combination of these things. I also want to mention that when we talk about systems, we're not just talking about healthcare systems. We're talking about transportation, housing, education, food security. There's a lot that these maternal mortality review committees are considering. And I'm sorry for the delay, but thank you, Christine. She shared there is a question in the chat on mental health conditions. In those mental health conditions codes, that does include deaths by suicide and by overdose. So I hope that helps clarify. And as I go on to slide 19, I have to show you some methodological information again, because we know that Black and Native women are disproportionately affected by pregnancy-related mortality in the United States because of the way we classify and categorize people by race and ethnicity. We had to do an alternative approach to classifying pregnancy-related deaths among American Indian and Alaska Native persons to understand what was their leading cause of death in these MMRC data and what did the preventability look like for those cases that were reviewed. So among 17 pregnancy-related deaths that were categorized as Native, if you go to slide 20, mental health conditions were the leading cause of pregnancy-related death. So if we go to slide 21, I mean, I think this is really what we can talk about today, is what strategies can prevent maternal mortality and reduce racial and ethnic disparities. So I've showed you that MMRCs provide data to understand maternal mortality disparities and the system structures and policies and practices that drive them. But what can you get from MMRC data that can help you move to action in your region? So if we go to slide 22, we're going to show you some examples of qualitative data that come out of your MMRCs. And these data can be very powerful. And, you know, thankfully, because pregnancy-related deaths are rare events, it may take some time for your state to be able to aggregate enough data to publish it and disaggregate by race. But what they do have and what they may be able to do is look at your qualitative data to understand what is happening and what potential opportunities for action lie in these data. So here we can see an example of facility and community level recommendations that came from MMRCs. I don't think it's going to be surprising to anyone here that access to care was a contributor. And then you can see how your MMRC would map a recommendation to that, such as expanding office hours and increasing the number of providers who accept Medicaid. You can see in that next contributor example that's shown here, it's unstable housing. Housing is healthcare. The recommendation that's mapped to this is to prioritize pregnant women for temporary housing programs. For the sake of time, I'm going to move to examples on slide 23. These are patient and provider level recommendation themes among pregnancy-related deaths that are listed in no particular order. A contributor is lack of knowledge of warning signs or the need to seek care. And the recommendation there is to improve counseling and increase the use of patient education materials on warning signs and when to seek care, such as the A1 Save Your Life discharge instructions. And I think what might also not be surprising to you all is on the bottom of this slide, a contributor is lack of continuity of care, and that we need to improve care transition protocols and communication between OB providers and primary care and specialty care providers. So my last example of qualitative data from your MMRCs is on slide 24, and these are systems level recommendations, and they include a contributor such as inadequate receipt of care. And the recommendation is to develop or expand implementation of policies that ensure women deliver at or are transported to a hospital with a level of maternal care that matches her health risk. And the states can work with their PQC to identify quality improvement procedures and periodic drills or simulation training for birthing facilities and include OB emergencies. So those are some examples, and sorry, I'll do one more from the system slide 24 on case coordination and management. You can see one here, extend or expand Medicaid eligibility during or within a year of pregnancy. So if we go to slide 25, I wanted to show you something that maybe you already are aware of, but we are working with all of the active maternal mortality review committees in the country. There are 49 active reviews in the United States now in 46 states and 2 cities. And this represents some real progress since I started on this work in 2015, when there were roughly only about 18 MMRCs. I'm going to show some examples of MMRCs, and maybe you'll see your own state here on slide 26. How have states used their MMRC data? Let's go to slide 27. In Illinois, they put out a report, and what followed the report was the legislature introducing 15 bills addressing maternal morbidity and mortality. And one of those bills that passed led to Illinois being the first state to extend Medicaid coverage for a full year postpartum. Several other states and MMRCs have followed suit in these types of recommendations, and the last I saw, 36 states and Washington, D.C. are now extending postpartum Medicaid. If you go to slide 28, here's an example from Utah. Utah saw that their leading cause of pregnancy-related deaths was mental health conditions, and so they prioritized a recommendation to educate providers on available mental health resources and specialists they can refer patients to in the perinatal period. And they launched a maternal mental health resource network and an Instagram page that last I checked had over 2,000 followers, which really shows the appetite of the public for information that's easily digestible in social media. And you can see, if you check out their page, Maternal Mental Health Utah on Instagram, you can see how their branding is consistent and really creates some nice recognition and flow through for those who follow their page. And if you wouldn't mind advancing to slide 29, data to action in Tennessee. Here's an example from Tennessee of a nice infographic. I think they recognize that the 100-page report might be hard for some folks to digest. So they created this graphic that showed that overwhelmingly the deaths were preventable and made some specific recommendations for healthcare providers, such as providing consistent screening, assessment, and treatment for cardiac conditions, screening and protocols for interpersonal violence, and systems of care for mental health disorders, anti-racism training, and increasing access to naloxone. If we go to slide 30, an example from Washington State. If any of you have ever sat in on a maternal mortality review, you may have heard that it gets frustrating to review a case with a very clinical cause of death when there isn't an autopsy report or an autopsy available. And Washington passed a law requiring birthing hospitals and centers to refer deaths of women who are pregnant or have been pregnant within 42 days to the local coroner or medical examiner's office, and importantly, provided a funding source for these autopsies. And the last state example is on slide 31 from New Hampshire. It's one that Christine and I were actually at a New Hampshire meeting a couple of weeks ago, and we gleaned from that meeting where they implemented care for pregnant and postpartum people with substance use disorder or patient safety bundle, provided provider education on how to obtain and distribute naloxone, and developed harm reduction education to reduce risk of postpartum relapse and overdose. And you can see the visual of a push card that they're using here on this slide. And I'm almost done. I know that there's some questions in the chat and we can get to the discussion portion, but just to show you the puzzle pieces again on slide 32, this is data that's meant to inform action. We want to fit together an understanding of the leading causes of pregnancy-related deaths, particularly by race, ethnicity, and fit that together with maternal health care standards, tools, and resources, so that we can prioritize right place, right time interventions and be sure that your communities are engaged. If we go to slide 33, you'll see on our website that you can go to review2action.org and go to our networking map. And if you aren't already connected with your state's MMRC, you can find ways to connect with them there and also see some of the resources that they've posted. So we can leave that slide up and maybe get to some discussion. I also wanted to mention that if anyone was at the MHLIC conference in Minneapolis this summer, I did present a data brief example, and we can look at that as well, but I didn't want to repeat too much of what you may have already seen there if you attended that meeting. Should I go to some of these questions in the chat now?
That's a great idea, Julie. And if you'd like, I actually copied some of them. So do you have access to the chat now?
I don't have access, but my colleague is kindly sending them to me. I see there's one. Are these recommendations in a specific CDC report? If so, which one? Were these developed through a CDC analysis of all recommendations, or are they just examples from states? So the examples that were shown on the earlier slides, and we can share these with you, were actually from the 14 state data that was from a few years ago. But they are from pregnancy-related deaths specifically. And they are examples from the data from the states. These are not CDC recommendations. These are actual recommendations from the states. And then there's a question, where does the failure to listen to or act on a mother's claims of concerns fall into the qualitative causes? I don't have an answer to that question right now because I don't have all of the aggregated qualitative data in front of me on that particular issue or contributor. Why are some states not CDC funded? I'm from Alabama. That's a great question. Actually, we are working with Alabama, and we have been working with the program there for years. We will be releasing another notice of funding opportunity for our next 5-year round early in 2024, and we are hoping that Alabama and all states will be able to apply and participate. And just because they are not currently funded doesn't mean that they are not participating. Alabama is actively using the Maria data system. And then I see a question, who initiated the legislation in Illinois? Did their MMRC have to pursue a legislative register in order to get the bill authored? That's a good question. I don't know if anyone from Illinois is on the line and wants to chime in, but MMRCs are generating the data. They're not necessarily the action arm, and being that they sit at the health department, it's not like they can author legislation. What the MMRC's job is to get the information out there to the people like you and other people who can work with legislators and other advocates to put a bill together. And some of you who might be involved with membership organizations like ACOG or SMFM might be familiar with how your chapters work on things like this and their policy agenda.
We also
I
received
see another question. Oh, go ahead.
We also received many questions that were entered at the time of registration that fell in a number of broad categories. One area relates to that handoff between the recommendations to who's going to pick up the ball and run with it. And you gave some examples of states that picked up that ball and ran with it. Julie, are you aware of systems of sort of tracking and monitoring the implementation of the recommendations or accountability mechanisms that states have put in place to, in fact, ensure that the recommendations are acted on?
I am not aware of accountability mechanisms. I mean, I think the folks like you are the accountability mechanism. Read your reports and see what recommendations by the leading causes of death, and hopefully by the disproportionately affected, how are those being implemented, and are those being connected to initiatives in your state? Yeah, the CDC isn't, we are collecting information on the people who are participating in our program and submitting the programmatic information, and we're asking them how it connects to their leading causes of death and to their disparities. But it's also the boots on the ground, the people in the state that are holding those groups accountable.
Right. One of the other areas that many of the participants, when they registered, had questions related to how to engage a whole range of different people in the MMRC process, stakeholders, communities, hospitals, patients, providers. Have you seen any changes in the makeup and diversity of MMRCs over time? And are there ways that you can recommend engaging as broad of a engagement in the process as possible?
Yes, we have seen movement in that area. Some of you, I know that there's some folks who are actively involved or staffing your MMRCs who are on this meeting now, but some of you may have seen that we worked with Black Mamas Matter Alliance, who put out a report on MMRCs sharing power with communities, and we can drop a link to that report in the chat. But that really was a sort of call to action for many groups who looked at it as an opportunity to be sure that their committee is more representative, so that the data that is generated there is reflective of the communities who are most impacted.
And just to build on that, Julie, I think in the coming months, BMMA will also be doing 2 webinars that really talk about that engagement they've had with the with communities in the MMRC process. So people will be able to hear more about that. Other questions in the chat? Also, while we're waiting on that, another area where a number of the questions related had to do with just the data analysis, and some related to the pregnancy associated versus pregnancy related causes, improving the reviewer process and interviewing of family members and persons affected by maternal death. Can you talk a little bit about some of the work in the area of the data analysis that's helped support states in that work?
Sure. While I can't see the specific question on the pregnancy-related focus, I think that's an important one for us to talk about. And I know we talked about it with folks who were there at your meeting in Minnesota. The reason why states are asked to focus on pregnancy-related deaths is because the Maternal Mortality Review Committees are the only group that are uniquely positioned, capacitated, and the only group that are specifically looking at deaths during and within a year of pregnancy and those that are pregnancy related. And so we ask them to focus on, and they do that by asking the question, if she had not been pregnant, would she have died? Now, if there are deaths in there, like a motor vehicle crash that had nothing to do with the pregnancy, it was incidental to the pregnancy, those aren't included in the leading causes of death so that we can, or they're not included in the pregnancy-related causes of death so that we can really focus in on the pregnancy-related causes. Other folks are working on transportation fatality prevention. But MMRCs are the only group that's uniquely capacitated to look at these perinatal period causes, and we really need them to focus on those. The other opportunity with focusing on pregnancy-related deaths is to understand disparities. If we look at all-cause mortality, an understanding or a clear view of the disparities in your jurisdiction will be diluted by the majority causes of death. I don't know if that makes sense or if that's helpful to the person who asked about the pregnancy-related focus, but that is our focus in our analysis and also in the tools that we give to states to focus on aggregating their data. I think there was another question about informant interviews that you read out, that we are providing a supplement to states to perform informant interviews and to hire, for example, licensed clinical social workers who are trained in grief and bereavement counseling to be able to conduct those interviews so that we can bring in the family voice. I see a question. This is a national public health crisis. Why is there not an immediate action plan at a national level instead of it being a state-by-state process where some without resources or who aren't prioritizing maternal health are being required to do something now? I mean, I think it's a good question. I appreciate the sentiment. There's definitely a lot of national conversation about pregnancy-related death as a national issue, and we appreciate that. The reason why we are focusing so much on the state level is because everything is local, and this country is pretty diverse, right? So every state is going to be different. If we say that everyone in America needs to focus on mental health deaths, we may be obscuring the disparities that exist perhaps here in my state, in Georgia. So we really need it to be a state-by-state approach. Everything is local, and we need those interventions to be localized if we're going to move the needle.
Mm-hmm. Any other questions? If people want to go ahead and add those into the chat. And while we're waiting for those, any other issues or areas, Julie, that you feel like emerging, or from the standpoint of the great work done in generating the recommendations, the hopes, the dreams, and thoughts about, how they're getting implemented. You described it as a action cycle. So at some point it all comes back to see, what's happening over time and what are the trends. Any thoughts on that, or just things you want to share about the iterative process and the hopes of seeing different trends?
Yeah, I mean, I guess I want to acknowledge this tension that we all need to do something now. We need to know what the information is now so that we can move forward. And we hope that we have made some data available now, and we know that many of you are already implementing actions to address some of these things. But I think we also need to balance that with very specific and comprehensive data so that we really understand what the problem is. And so I think that some of that balancing act is that some of the interventions that have been implemented state by state are not necessarily their leading cause of pregnancy-related death. And so I think it's just a time for us to kind of do both things at the same time, or think as you're thinking about your next action initiative on the horizon, really consider, if you're not already, looking at your state MMRC report and then asking your team if it's possible to disaggregate by race so that you can get at those disparities in your action. And I know I've said it before, but I will say it over and over again. I think it's an important thing for folks to understand that's a little bit nuanced. I think there was a question in the chat, a plan to separate deaths from suicide versus drug overdose. Certainly big states, and really all states, but especially big states, you can separate your deaths by suicide and drug overdose and analyze them that way. You can look at preventability by cause of death. You can do all that with your state team, especially in larger states.
Hi, can you hear me? This is Christine. That was my question. I was specifically referring to the CDC reports that come out that aggregate all of that. I'm wondering whether the CDC has plans to disaggregate some of that data in their future reports. Because I feel like I mentioned in the chat, California has a fairly low suicide rate compared to suicide among people of childbearing age, and we don't look at those deaths. But we also get a lot of comments from advocates about, the high preventability of overall of all maternal deaths. And so by, those maternal health conditions, those mental health conditions, I think typically have a high preventability. And by combining preventability among all causes of death, I feel it's harder for states and advocates to understand that different causes of death have different levels of preventability. Thank you.
Yeah, I mean, I think as these teams look at these deaths from so many different angles, I think many of them are going to be considered preventable by many of the causes. And, Christine, thank you for your question. In terms of aggregating the data nationally so that people can use it to inform action, I am not aware of a plan to disaggregate among the mental health conditions, to separate out, for example, deaths from substance use disorder versus deaths from other mental health conditions. But in terms of the cardiac conditions, we're actually grouping them a bit more. We're going to be grouping cardiac and coronary conditions and cardiomyopathy into one category, because folks have been asking us why we're separating them. And in fact, when you group them, they overwhelmingly become a leading cause in some states. So we appreciate the questions and the dialogue, because this program is certainly living and growing and is informed by the field. I think there's a question, do all 50 states have MMRCs? And if not, why not? It's a great question. Most states have active MMRCs. One is on a hiatus right now, Idaho. Some of you may have read that in the press, but hopefully they will be back soon. There's another question. Are there any unique ways of measuring how well recommendations become action? Specifically, are states doing things that keep transparency with the community about what they are doing and reporting back on the impact of those recommendations? I know there's some other project officers on the line with me here today from CDC. I don't know if other state examples come to mind. I mean, I think transparency is to get the reports out there and to disaggregate by pregnancy-related deaths. I'll underscore that again. And then understanding what are the recommendations to address the leading causes of pregnancy-related deaths in the state. I think that's the transparency, is getting the information out there so the community knows what to do.
Yes, this is Brittany Willis. And I know, for instance, like Illinois, what they do is that they gather a smaller group of or a group of maternal health leaders within the community to talk about what are the recommendations that have been implemented, to review the action items to implement those. So I know, for example, Illinois does get together, I think quarterly so far, to review recommendations.
Hi, my name is Christine Cooper Nowicki. I also work with states, and I do want to just add to the conversation. It depends on the partnerships and the MMRC reports. So most like what Julie said earlier, the MMRC's goal is to get that data out. They are often not the implementation arms, and so when they put those recommendations out, they are working with partners to see who is implementing them and being able to share those stories as they're aware of them. But that could look different from state to state and group to group, and also depending on which recommendations are being implemented.
Great. Julie, I noticed in one of your initial slides on the pyramid of compiling the recommendations, the look at near misses. And are there ways in which the information relative to near misses can be used to, presumably the near misses are more frequent than the actual deaths, and whether we can be learning from those as well?
Yeah, that's a FAQ, and it's a good question. I think what may be helpful context or to put this in perspective is that we are working really hard with states to get them in a place where they have the resources to identify all the deaths within 1 year and to review all the deaths within 2 years. And in some states, that's a pretty aspirational goal, and it's pretty difficult to meet. So imagine if we added in severe maternal morbidities, which could be like 50 times as much. And what we're realizing is that the causes of pregnancy-related deaths are the same as the causes of near misses or severe maternal morbidities. So if we can get every jurisdiction to comprehensively review every death in a multidisciplinary way and make recommendations and publish them in a timely way, then we will be getting at the near misses as well, right? So I just want to acknowledge that the volume of deaths in some states is so overwhelming that they can't get to be current. So if we added in near misses, it would be absolutely impossible. And so while as unfortunate and awful as those things are, we really need folks to focus the limited resources we have on the deaths and do it well, and then get the information out there so that we can not only prevent the deaths, but also prevent the morbidities.
Great, thank you.
Yeah. And, I'll just say we can provide the slides and follow up the PDF version, and we can also provide an example of a data brief that's focused on deaths among Black women and how we used qualitative data. And we can distribute that, and it includes a story. It includes a vignette that's based on real stories from MMRC data, and that can also be very powerful for helping your decision makers move toward taking action. Oh, I see someone asked again about how does an MMRC go from funded inactive to funded active? What is the difference? There are a handful of states now who are currently not funded, but we are hoping that all of them will apply to the next 5-year funding opportunity that is coming out in early 2024. Some states have had barriers in being able to apply because they weren't able to identify deaths in a timely way, or they weren't able to enter into a data sharing agreement so that we could support their aggregate analyses and their data quality. But many states are moving toward being able to do that. And so we are hoping that all 50 you will see as lit up and active, so to speak. We are helping them get the tools they need so that they are eligible to be funded.